Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. And Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. And our goal is to spark conversation, ideas, and action. Since we're live today, I want to remind everyone how to ask questions of the presenters. You do so by typing your questions into the question box at any time. I'll check for the questions periodically through the session and we'll address them at the end of the session. But you don't need to wait until then to type them in. Just go ahead and type away as you think of them. We're delighted today to welcome another Children's Healthcare Canada member, BC Children's Hospital, to bring you a three-part webinar series related to neurodevelopmental disorders. Today, we are pleased to host the first of this series, Autism Plus, Identifying Comorbid Psychiatric Conditions. For those of you on Twitter, please tag us at Child Health Can and at BC Children's Hospital, HOSP, on any webinar-related tweet and share away. And I would like to introduce the first of our speakers. Dr. Jennifer Russell is a child and adolescent psychiatrist at BC's Children's Hospital and the clinical director of the COMPASS program. Jennifer will introduce her co-presenter and colleague, Dr. Robin Freelander. It's my pleasure to pass the mic to Jennifer.
Thank you so much, Paula. Robin and I are delighted to join all of you today to talk about this really, I think, poignant and necessary topic about Autism Plus, managing during COVID. Today, I wanted to give you a bit of a history. The COMPASS program is a new program at BC Children's Hospital. It's the first provider support program in Canada, where our goal is to provide evidence-based, rapid mental health support to people who are taking care of children and youth across BC. So our program is open to any provider. We're completely multidisciplinary, and we receive calls from across the province every day. Since COVID, we noticed a significant increase in the number of calls we were getting with patients who had neurodevelopmental and neuropsychiatric disorders. And in collaboration with our partner in Northern Health, specifically Jen Begg and her colleagues, they had requested additional training and support so that we can manage these cases better over the next year as COVID has become our new normal. We decided to do the format of this series for a few reasons. The first is I'm a generalist. I'm a general child and adolescent psychiatrist with no specific extra training in neuropsychiatry. And I'm sure, like many of you, these cases can often be quite daunting and complex, and it's hard to know where to start. But over the past couple of years, from getting support with colleagues like Dr. Robin Freelander and the clinic at BC Children's, I've learned that there are some things we can do to support children and youth while they're waiting for subspecialized services. This has become even more paramount with the COVID pandemic, where many of these children lost their services such as school, respite, and other subspecialized services that were keeping them and their families well prior to the pandemic. So before we begin, I wanted to introduce Dr. Robin Freelander. Robin is the clinical medical director of our neuropsychiatry program at BC Children's Hospital and arguably one of the top experts in Canada. And it's been an honor to be able to consult and learn from him over the past several years, and it's a real privilege for us to have him here today. Robin, was there anything you wanted to add?
No, thank you very much, Jen. Looking forward to this.
Okay. All right, so let's get going. So Robin and I have nothing to disclose. There's no psychopharm funding or anything through this talk. And when we're talking about medications, we're referring in large part to general guidelines that are noted at the bottom of the slide and our own clinical views. So the series is going to be 3 parts. The first session is Autism Plus, an approach to comorbid psychiatric presentations, which you're listening to today. There's then going to be a session next week, same time, with a specific goal to review an approach to managing aggression in patients with autism and other neurodevelopmental disorders. And then the third session, we're seeking case presentations and review, where Robin and I and a parent with lived experience will come together to review cases. We're hoping that people who are listening are going to email in cases, and they'll get the email information at the end of the talk that they would like us to discuss, and then we will prepare those cases. If we don't receive any emails, then we will prepare some cases for discussion. So the learning objectives. So we had 3 specific goals for today. The first is that we want to review what is autism, and I've just lost it. What is autism, and FASD and intellectual disability. We want to review some of the common comorbid psychiatric conditions and approaches on how to manage them. We're not going to be able to cover all psychiatric comorbidities, but if there are ones that you're interested in, please feel free to email in cases, and we will put that in the third session. We also want to focus on a key concept that we refer to as diagnostic overshadowing. This is where there's a clinical error where people attribute every symptom to autism, and as a result can miss symptoms of underlying psychiatric disorders. And we're trying to highlight that throughout the presentation. And throughout the session, we're going to review cases. All cases have been disguised to protect confidentiality and slightly modified for that reason. So why is this topic important? The impact of COVID-19 has been significant on all of our lives. Here I am in my basement presenting, which, a year ago I never thought what I would be doing. However, in my opinion, that the COVID-19 has had many other silent victims that we haven't been talking about on the news, or that many people aren't aware of. And it's clear that children and youth with neurodevelopmental disorders and their families are part of this silent group. Within a matter of hours across Canada, all of these children and families lost most of their supports in a very abrupt fashion. These are children that often require extensive multidisciplinary support, and many of them were doing quite well prior to COVID, with a combination of family support, school support, support from the healthcare system, and agencies such as MCFD or Children's Aid. A lot of these relationships or respite were stopped due to the pandemic, causing these families and youth to go into a transition. Unfortunately, as many of you know, children and youth with neurodevelopmental disorders often don't cope with transitions in the same way as their neurotypical peers, which highlighted the stress of the pandemic. And many parents were forced into 24-hour childcare while also having to work and cope with the pandemic like the rest of us. As the pandemic is going to continue, we wanted to make sure that this population continued to receive excellent evidence-based strategies. And so our goal is to review these common neurodevelopmental disorders and strategies with the goal of improving clinical care across Canada throughout the pandemic. So when we look at these neurodevelopmental disorders, it's often interesting to look at them along a spectrum. Many youth will have specific individual disorders, such as FASD, intellectual disability, or autism. However, there's many more children that have overlap or more than one disorder. Or from what I've seen in BC, we also have many that are still pending assessment. Now, the assessment wait list here in BC, and I'm sure it's similar across Canada, is often quite long. So it's not uncommon to get calls or have families in crisis where they don't even have a diagnosis. I have found it helpful to actually just assume they have the diagnosis and try to start treatment while we're waiting, because the vast majority of the time, these youth do require the extra support. And in the odd case where they don't have a diagnosis, the child has simply received extra support, which in my opinion isn't harmful. Robin, is there anything else you wanted to add to this?
Nope.
Okay. So intellectual disability, we're going to start off with just going through the first, what they are. So intellectual disability is when a child has a significant limitation, both in intellectual functioning. So by that, I mean things like reasoning, learning, problem solving, in addition to difficulties with adaptive behavior. So this will cover a wide range of everyday social and practical skills. For example, achieving developmental milestones like getting dressed, being able to follow through with basic activities. And these impairments have a significant impact on their day-to-day functioning. In order to meet the criteria for this, these difficulties have to happen before the age of 18, and often they're diagnosed in the early years, often before age 3. Robin, do you want to continue?
Yeah. So, Hi everybody. So we just wanted to talk briefly about intellectual disability and fetal alcohol syndrome disorder, spectrum disorder, before we move on to autism, which is going to be the rest of the talk. But pretty much everything we say about intellectual disability and FASD everything you say about autism is going to be true in terms about intellectual disability and FASD in terms of the concept of diagnostic overshadowing. So just to remind you that fetal alcohol spectrum disorder, with the new Canadian criteria, you can either have fetal alcohol spectrum disorder with sentinel facial features, which is a particular facial characteristics, and there's always going to be alcohol exposure. There's going to be some kind of impairment in central nervous system functioning, and there's going to be the facial differences. And if you have FASD without the sentinel facial features, then you have alcohol exposure and CNS impairment. The impairment on the brain can be quite significant because the brain develops throughout the 9 months of pregnancy, whereas the facial dysmorphology is only going to happen if you have exposure at a certain critical time within the first couple of months of pregnancy. Next. So I just wanted to bring this up, talking about diagnostic overshadowing. It was an article by John McLennan in Alberta in the Canadian Journal of Psychiatry, where he talks about one of the problems with FASD diagnosis is that the new Canadian guidelines may contribute to confusion about the interface between FASD and mental health problems. So if you remember, I said that one of the key criteria for the diagnosis of FASD is impairment in the central nervous system, in the CNS. So mental health systems, classic mental health symptoms, such as inattention, hyperactivity, impulsivity, anxiety, affect dysregulation, pretty much the kind of thing we see every day in a child psychiatry clinic. These may be counted as for the domain of CNS impairment, and therefore contribute to the diagnosis of FASD. So in other words, if the mother drinks in pregnancy and has sufficient of these mental health symptoms, they would get a diagnosis of FASD if the symptoms were significant and severe enough. And so this potentially can cause one to miss comorbid psychiatric diagnoses which are treatable in someone with a diagnosis of FASD.
Okay, and in addition, the third disorder we're going to talk about today, and this is, as Robin said, the main bulk of the presentation, is autism. And autism has three main deficits that youth with autism experience. The first one being persistent deficits in social communication. Second being restricted repetitive behaviors, interests, and activities. And these difficulties need to happen in the early developmental period. They cause clinically significant impairment in social, occupational, or other areas of life. And the disturbances are not better explained by intellectual disability. We're finding that many of these youth are diagnosed earlier and earlier in Canada, often by age 2. And so treatment plans are often in place. However, autism changes as a child develops, and throughout the lifespan, you may see different issues coming up. So the diagnosis is really the first step, but learning to manage across a lifespan is important.
So one of the reasons that autism became topical and funded to the way it is currently across the country is because of some work suggesting that if one provided early intensive behavioral intervention, around 40 hours a week of this intensive intervention before the age of 6, that one may significantly change the trajectory of autism, and that these kids would be significantly improved. And this led to funding for across the Western world, really, for this so-called EIBI. Unfortunately, however, the evidence that EIBI is very effective has not been demonstrated. And this is just a Cochrane review. Cochrane is a well-known system for assessing evidence-based treatment in medicine. And the Cochrane review essentially showed that there was either no evidence or very low quality evidence that EIB improves adaptive behavior, IQ, autism symptoms, or problem behavior. Next slide. So the key point is that many children are diagnosed with autism nowadays, as Jen said, at a very young age, under the age of 4 typically. But one would expect that if they have behavioral issues in early childhood, they will probably continue to have behavioral issues throughout their life. EIB is not as successful an intervention as we had hoped. I realize that is kind of heresy to say that, but that's the way it is. However, the good news is that a lot of the behavioral problems are related to psychiatric comorbidity. That we can address. That's what we do in mental health. So that's why we're talking. Next. So how do children with autism present? Well, they don't present with necessarily an autism label on their forehead. They present with aggression. And that's pretty much how many kids present to mental health. Aggression, non-compliance, not listening to adults' requests, disruptive behavior, hurting themselves, sleep problems, moodiness, irritability. And what happens is at a certain point, the parent's ability to deal with this is exhausted. And it depends on, each family has their own breaking point, depending on their support system and their own resources and how challenging the child is. And the parent's exhaustion is what drives the crisis in the system. So one of the things one can do, and I think this is something that really should be offered to every parent who gets a diagnosis of autism from the beginning, like when they at the age of 3 or 4 when they're getting these diagnoses, is to provide a parent training management training to help them with managing behavioral problems. And here's a little study looking at the effect of parent training versus parent education on behavioral problems in children with autism. It was done by Bears. 180 children, preschool children to grade 1, autism and behavioral problems. Both treatments led to improvement, but parent training was superior, was better than just giving parents information. In terms of improving disruptive and non-compliant behavior. So parent management training is effective and should really be the first step, I think, with any child who gets this diagnosis.
And just to add, Robin, to what you're saying, this is something that I think can be adapted to virtual care. So with one of the things that's happened with COVID has been an explosion in the ability of clinicians across Canada to offer virtual care. And parent training and parent education via different platforms is something that can be offered, I think, even in a lockdown state where parents are struggling to manage the behaviors of their children. And I also think that it can't be understated that having regular contact with a primary health care professional or clinician, I think significantly adds support to these parents in particular that are dealing with really complex and challenging situations or behaviors in their children in the context of a crisis like COVID. So now we're going to get into some of the comorbid mental health conditions that are associated with neurodevelopmental disorders. Part of why we're doing this is because common things being common. Often, as Robin said, when these children present, they don't have a diagnosis, or they do have a diagnosis of autism, but there's many other symptoms. And it can be hard, especially for me as a generalist, to kind of figure out, okay, how do I approach this case? So if we look at, and this is from the AAP 2020 guidelines, which I recommend as a great source of further reading for people, the most common mental health conditions in this population are ADHD, anxiety, depression, and bipolar disorder. And what I have found helpful, if we look, and this is a developmental timeline, and we want to give thanks to Dr. Vic Dua, who developed this. When you look at a child's age, it can also help you approach the case. So if I receive a consult on a youth who's, say, 5 or 6 years old, and they're presenting, as Robin said, with aggression, sleep issues, self-injurious behavior, I immediately think to what are the more common mental health conditions. So, for example, ADHD in this situation. When you get a similar presentation, again, non-compliance, aggression, sleep issues in a teenager, I'm more likely to think about things like catatonia, depression, and bipolar disorder. It's not that you can't have these other diagnoses at different ages, but it does help you. And with common things being common, I have found this to be a helpful approach. Anything you want to add to that, Robin?
No, just to note that anxiety at the top can occur at any age. And anxiety is really quite a pervasive problem that it's not easy to pick up. It can be quite masked, as we all know, and it's treatable. So that's why one should always think about anxiety across the lifespan.
Well, and actually, that's to highlight this. Like, all of these psychiatric disorders here are treatable, and they result in a significant improvement in quality of life for both the youth and the family. So this is why I think it's really important to focus on them. Now, the one that I think is the most important is sleep. 50% of children and youth with neurodevelopmental disorders have had persistent sleep problems. And, you know, I think back to my own experience being a new mom and being sleep deprived and how difficult this was. This actually really highlighted for me in a way that I wasn't sensitive to before becoming a parent about the impact of a child's sleep on the entire family. If a child is not sleeping, usually the parent is not sleeping. And this is particularly true in kids with neurodevelopmental disorders who often might be up, hurting themselves, aggressive. They're not settled, like lying in their bed or reading a book quietly. So this is an area that can cause like really significant disruption to the family, and is quite treatable. So the first thing that I think is important is to ask about sleep, and to make sure you get a sleep diary, and in particular to focus on, was the child sleeping well and there's been a change, or is this a chronic problem? Many of the times, other issues have presented clinically more important than sleep, and I find that sleep can be a chronic, persistent stress for both the youth and the family. And when you're able to restore someone's sleep, I find that their whole quality of life is better, and almost every psychiatric disorder is improved when you improve sleep. So the common interventions that work well for this, and again, getting back to Robin's point about parent training and education, is going through with parents specifically what's happening in the home, and going through common sleep hygiene principles, such as routine, having a regular bedtime, having OT intervention to figure out, is this a youth who, say, needs a weighted blanket or no blanket? Sounds, different textures, things that can help, and getting into a routine that supports developing sleep. And then having strategies with parents, what to do when their child wakes up during the night, how to manage it. One of the things I've noticed clinically is often parents have different views on how to manage these middle of the night interruptions, which can be a source of marital conflict, and coming together with a clinician with a united approach can also really improve things. Once you've tried that, or to supplement that, common medications that help, obviously the first one is melatonin, clonidine, using antihistamines, iron, which is, I know, a little controversial, but here at BC Children's, we found that many of these youth actually have iron deficiency, and when iron is replaced, their sleep can dramatically improve. I've seen this within a 2-week period. And when those medications don't work, trazodone is also really helpful. Sometimes when picking a medication, it's important to look at what else is going on. So for example, if the youth also has ADHD, clonidine is an effective treatment for that. And so you can get a double bang for your buck. So as I mentioned earlier, oh, Robin, you go ahead to this.
Okay, so this is a really nice book by Mark Durand, who's a behavioral psychologist down south. It's called A Guide for Improving Sleep for Children with Special Needs. It's a great book. Just to emphasize Jennifer's point that I see parents whose kids are 8 or 9, and the kid has never slept through the night. Can you imagine? They haven't slept a good night in 8 or 9 years. This is a huge problem. It seems to be part of the neurodevelopmental disorder that these children have a huge difficulty developing a good sleep routine and sleeping through the night for various reasons. So, great book. Next. So this is a study that was done actually at BC Children's Hospital, published in the, I think, obscure journal of the Journal of Pineal Research, but the reason is because melatonin secretes in the pineal gland. So these were children with neurodevelopmental disorders like autism and intellectual disability who just had not responded to sleep hygiene. So they done all the right sleep hygiene measures that Jennifer mentioned. They still weren't sleeping through the night. They either couldn't fall asleep or they woke up repeatedly during the night, or both. This study used controlled release melatonin, and they found it was an effective treatment of disorder, what's DSPS, Jen? Delayed sleep phase syndrome, and ISM. I can't remember what that stands for, but basically it's waking up during the night.
Impaired sleep maintenance.
Thank you.
Impaired sleep maintenance, so waking up repeatedly through the night.
Yeah, you can see I did this slide a few years ago. In children with neurodevelopmental disorders, including autism. So melatonin was very effective. What I wanted to say is that it may be that melatonin pathways are disrupted in children with neurodevelopmental disorders. It may also be that the environmental factors, such as a dark room and less stimulation and taking away your electronics, don't work as well in children with neurodevelopmental disorders like autism. Whatever the reason, these children respond well to melatonin as a rule, to be the first line treatment, extremely safe. You may have to go high dose. You may have to go to 10, 15 milligrams a day. You may need a combination of short and long acting or controlled release melatonin. And many of these kids can't swallow pills whole, in which case you have to use regular short acting melatonin. Jen?
Yeah, I think oh yeah, sorry. Okay, yeah. Oh yeah, there we go. Okay, so we wanted to review one case we've had recently on the Compass Clinic, where we received a call about a youth named Mary, who is a 9-year-old youth with autism, average IQ, and has very loving parents. And however, things had really hit a breaking point. The parents were exhausted, had to take time off work. The marriage was in trouble. And most of this originated from long-standing difficulties with sleep and behavior. When I met with this family, it turns out that in 9 years, neither parent had slept more than 4 consecutive hours. They were actually alternating waking up every 2 hours with their daughter. And when she woke up, she was very distressed, banging her head, moaning. It was quite hard for them until they could help get her back to sleep. And when you met with the parents, like the mom developed a clinical depression, which is not surprising given, 9 years of interrupted sleep. So how did we approach this case? Now, again, I wanted to point out, I'm a generalist. I'm not like Robin. So I just started off by getting a really detailed developmental history. And that's where I found out that this sleep has actually been a chronic problem really since birth. And because of the increased difficulties, she wasn't functioning at school like she did previously. And things the parents talked about was her ability to handwrite, her ability to sit in class, her ability to do math had all deteriorated. We really focused on the sleep issues. I obviously still put in a referral to the neuropsych clinic, but that can be a wait. So I chose, okay, what's the one thing I can do to support this family? So I put in an urgent referral to see a sleep specialist, and we did a full metabolic workup, and it turns out that Mary was low in iron, and so that was optimized, and we started melatonin for sleep. We also advocated for parent support because getting, again, the parent training and coaching through this really difficult time is important, and they started meeting regularly with the mental health team in their area. We also talked about the importance of medication adherence. One thing that I've noticed is often when things get better, say with sleep, parents will stop the medication, but then the problems often return like weeks to months later. So we talked about making sure that once we got the sleep really restored, to keep up with the same routines until they were able to meet with their team again before making decisions. We talked about how this was slow and steady. The parents started keeping a sleep diary, and the amount of night wakenings slowly started to increase. And within a 2-week period, Mary was then actually sleeping through the night. And the family was significantly better. And a month or two later, the family actually felt that Mary was back to her baseline. Another case we had on the COMPASS team was a 4-year-old youth with autism and suspected FASD. And again, when I hear a story like this, I don't wait for the diagnosis. I'm assuming he likely has it. And although we still sent him, obviously, for a complete workup, but how do we treat him, assuming he needs those supports? And this little guy was one of the hardest cases I've actually ever seen. He was in, again, a really loving foster placement. These parents were doing their utmost to attend and support him. He was up all night, basically couldn't sleep, destroying his room, smearing feces everywhere, head banging. He was actually covered in bruises from self-injury. So with this case, given like the severity of his sleep disturbance and that it was, I think, appeared to be an acute onset, we did recommend that he attend the emergency room for an urgent physical exam to rule out, is there a physical cause? Again, looking at his age and the behaviors that the foster parent was seeing during the day, I highly suspected ADHD. So we started clonidine for sleep and the ADHD symptoms, and over a 3 to 4 day period, he dramatically increased, and then he started sleeping 12 hours at night. There was then a few days where he had some difficulties. We increased the dosage, and he resettled, and he ended up doing really well and was able to be transitioned back to a family member's care, which was extremely significant. What was interesting to me clinically, we did refer to the infant psychiatry clinic here for ongoing treatment, but within a few nights of sleep, he became much more settled, started to play, had frequent smiles, and actually when he saw me at the hospital, actually took my hand. And this was a youth that, like, when I first met him, I don't think even registered that I was there. So again, significant improvement with fairly basic steps of treating the sleep disorder in the context of neurodevelopmental issues. So now we're going to transition onto ADHD. Robin?
So ADHD, firstly, ADHD is one of the most, well, we know it's the commonest psychiatric disorder in childhood. And not surprisingly, it's even more common. I think it's about 10% of boys. Is that about the right rate nowadays? But if you have autism or another neurodevelopmental disorder, it goes up to 50%, incredibly high. Important thing is that medications that target ADHD will help impulsive behavior and hyperactivity. Stimulants are not always as effective and may have more side effects if there's concurrent intellectual disability. So if you have autism and intellectual disability, especially if the intellectual disability is quite significant, then stimulants maybe shouldn't be your first choice, but they still can be effective. Sometimes you use atomoxetin or Strattera if there's comorbid social anxiety, and another option is guanfacine or clonidine for ADHD. So, next one. Is this still me?
Yeah, I think I was supposed to. I'll do this one, Robin. Okay. So I think what Robin is saying that I've really learned over the past couple of years is ADHD is so common in this age group, and people often dismiss the symptoms as saying, oh, they're part of autism or they're part of FASD. And one clinical pearl that I've learned is that impulsivity can be more than just physical, like poking. It can also be emotional and verbal. In learning from Robin, emotional dysregulation can be a core feature of ADHD. I know this is not listed in the DSM, but it is quite common. And I find that there's sort of two types of kids. There's the externalizing kids who will act out and be aggressive, and they're often diagnosed with oppositional defiant disorder or conduct disorder. Or you can get the internalizing kids that will want to kill themselves, say things, I want to kill myself, or really draw into themselves. One thing with autism that makes it more difficult to diagnose is that the core feature of being unable to see someone else's point of view or mentalization can sometimes be seen as a lack of empathy or remorse. And this part could be part of the social communication difficulties of autism and not part of psychopathy, although these youth are sometimes seen in that manner. So really, when I hear about significant aggression and difficulties in this population, especially with the younger age group, often impairing their ability at school and at home, ADHD is the first thing that comes to mind. And a couple other clinical pearls. People are really worried about stimulants in this population, but when they're with the people who are at higher risk of developing a substance use disorder are youth with untreated ADHD, not the youth who have it treated. Because of that, these youth are actually not more likely to develop a stimulant dependence. However, medication titration can be trickier, as sometimes these youth have a more sensitive brain. As Robin said at the beginning, the CNS system in the body has been impacted. This affects all medications. And so sometimes it does take a little bit longer to figure things out. But that being said, there are really high gains when you take the time. Many of these youth significantly get better. So Robin, your case?
So I have a brief case. So this is a 11-year-old young man, lives at home with his family, got a diagnosis of autism at the age of 4. He's had a long history of physical aggression towards family members. He's very restless, intrusive, demanding. He runs away to avoid demands. He's really oppositional to parental requests. He's very boisterous, so he'll get into the dogs and play with them too vigorously, and when the dogs don't like it, he doesn't recognize their cues. That's enough. He can't manage in a regular school program because he's so disruptive, and he has problems falling asleep. Next slide. When we met with him, the mental state evaluation showed that his voice was somewhat loud, his speech had an unusual prosody or rhythm and cadence. He spoke in an overly formal way. That's the autism piece. Then the ADHD piece, extremely active, intrusive in the office, persistent, limited response to redirection, couldn't stay in the office, very demanding of his mom's attention and irritable if he couldn't get it. Not surprisingly, the SNAP rating scales were very indicative of ADHD. Next. He ended up and actually did really quite well on Foquest, which is a very long-acting stimulant related to Ritalin, and clonidine at night for sleep. And he's done quite well. So
Robin, oh yeah, go ahead.
So the next is anxiety, and I realized so anxiety, once again, very common. 40 to 50% of school-age children with autism have anxiety, significantly higher than the general population, at least double the rate. Most frequent are specific phobias, generalized anxiety disorder, separation anxiety disorder, and social phobia. Kind of interesting that you think autistic kids aren't interested in other children, but autism is a very heterogeneous, mixed bag of disorders. It's not one disorder. And so a lot of these kids actually do want friendships and are quite socially anxious. So next. So just to let you know, there is actually an evidence-based group therapy treatment for children aged 8 to 14, where the children are seen with their parents. The treatment is for addressing anxiety in kids with high-functioning autism who have anxiety. Just to let you know, that's the term high-functioning autism doesn't mean that the autism is not so bad. It means that their intellectual abilities are average and not in the intellectual disability range, essentially. Next. So the English, I think you're quite good at these sort of things, have got a working group called NICE, N-I-C-E, and they recommended modifications to apply CBT to young people with autism and anxiety. And the kind of things that they think we should be doing are, one, helping these children recognize emotions. Secondly, using written and visual information and structured worksheets far more than usual. A more cognitively concrete and structured approach. In a way, what we're saying is perhaps a little less of the C and more of the B, less cognitive and more behavioral. Simplified cognitive activities such as multiple choice worksheets, involving a parent or carer to support the implementation of the intervention. For example, involving the parents in the therapy sessions far more than you normally would. Maintaining attention by offering regular breaks, and trying to incorporate the child's special interests into the therapy to engage them. Next. So essentially, an emphasis on recognizing emotions, increased exposure opportunities with positive reinforcement for exposing oneself to the feared situations. That's the B part of CBT, and parental involvement. Those are the three keys.
And Robin, just to add to this, I also believe that this treatment can be delivered virtually. So when we're in a COVID pandemic, still doing things like cognitive behavioral therapy with these youth online is definitely worth trying.
Next. In terms of medication, serotonin reuptake inhibitors like fluoxetine, we tend to start with sertraline because we find it's the least activating of the SRIs. We tend to start low. There's a high risk rate of behavioral activation in children who have, well, in children generally, but especially children who with neurodevelopmental disorders, where they become, we'll talk about it under pharmacology, but you got to be careful starting these drugs low. Alternatives are clonidine, guanfacine, or venlafaxine, but I very rarely need to go to venlafaxine. I find SRIs generally do the trick.
So one case to highlight this that we received during COVID, about a 17-year-old youth in grade 12 with very high functioning ASD. He was expected to graduate this year, go to university. And when COVID stopped his school year abruptly, he was extremely devastated by this. It had been his most successful year socially. He lived at home with a single mom who was very loving and attuned. However, he started to have significant outbursts where he would threaten and try to hurt his mom, but was totally fine outside of these outbursts, at least on the surface. Things escalated and 911 was called, and he was taken to hospital, which was quite traumatic for him. And unfortunately, this made him more agitated. And in the hospital, he was quite agitated. It required seclusion and emergency medication. He was initially diagnosed with bipolar disorder and put on risperidone. However, the family doctor, who knew him quite well, didn't agree with the diagnosis. And we did a detailed history with Mom and Johnny, and we wondered about anxiety being the underlying issue. He was started on an SSRI and clonazepam, and I gave clonazepam mostly because it works right away and also because of the severity of the aggression in this context. Now, what was interesting is he started therapy with his local child abuse mental health team. And what was causing him a lot of anxiety was actually dating and learning these social rituals, which was quite interesting. And they were able to continue therapy online. And he was gradually tapered off the risperidone and ended up doing well and finishing the year. So he graduated on a combination of fluoxetine and the clonazepam, and we're now gradually lowering the clonazepam. So to summarize, before we get to questions, a couple of key points to take away from today. That the early intervention behavior training with this population, autism, is not necessarily as effective in managing these behaviors as initially believed. Parent training is effective and should be offered. Many children and youth with neurodevelopmental disorders have comorbid psychiatric disorders. These disorders change as they grow up, and these disorders are treatable. So as clinicians, it's really important that we avoid making the error of attributing everything to the neurodevelopmental disorder and thereby missing treatable psychiatric conditions. Robin?
So clinical pearls, take a history. From when did the problem start? Has it always been there, or is it something only that developed more recently? This helps you decide on what the likely underlying cause of the behavior is. Focus on what their baseline was, because they may have always had some problems, but now they've got massive problems. So something's changed. Get that history. Use screening tools as needed with the parents. Focus on what is common in different age groups. As we talked about that graph earlier on, where ADHD is common in young children, but bipolar would be very rare in young children. Treat comorbid psychiatric concerns aggressively, and these kids and families often need quite frequent meetings to support them.
Okay, so before we take questions, I just want to remind people, if they have cases they'd like us to review in the third week, to please email Paula at this email address. And I think, Paula, we're ready for questions.
Wonderful. Thank you both, Robin and Jennifer. We do have a few questions. I also encourage folks to type them in now as we're beginning to take them, and we'll address them as we go. So the first comment or question is, will you be talking about mild autism or Asperger's, as in their clinic, they're seeing an overwhelming amount of young people who are previously undiagnosed, particularly female youth?
We're happy to review any cases with across the whole spectrum, so please send in a couple of cases for the third week. I would agree that from a generalist perspective that I've seen an increased number of cases, particularly with teenage youth that are high functioning, getting diagnosed at a later age, often because sometimes the symptoms, I think, present differently in different genders. And these kids have fallen out of, like, under the radar, and that the social nuances of high school have sometimes led people to realize that there's more going on. But I still think the same approach is helpful when someone is a teenager who may have a neurodevelopmental disorder and we're waiting for testing. It's still really important to look at the possible comorbid neuropsychiatric disorders like anxiety, ADHD, and depression, and start treating those while the person is either waiting testing or getting those supports set up. I know, Robin, do you want to comment on that?
No, I think it would be really helpful to, if the questioner could send us a case that illustrates this, that we could talk about in the third session, because I think the whole definition of what is mild autism is a discussion in itself, and I don't know if we've got time for that today.
Is there a particular format you would like the case presentation to be in?
Oh, thank you. I think people could send us a brief case history similar to the cases that we something with the key points that, like the case that we presented today, that could be perfect. And maybe if this particular questioner could mention that this is one of the questions that came up in the session, so we know to highlight that case in the third session.
Perfect. Thank you. Judy has asked, can you explain the difference between parent education and parent training? And is there a parent training program that's evidence-informed or based and readily available for organizations to use?
That's a great question. So the first thing is parent education is explaining what autism is, and parent behavioral management training is a way of helping parents understand their children's behavior and modifying it using basic behavioral parenting principles. In terms of programs, there is one program that's available across Canada, because I've got to think of Canadian programs. Do you remember what it's called? The one, Thriving Kids?
Confident Parents, Thriving Kids, that one?
Yeah, that one.
I don't know if that's available across Canada, Robin, or if that's just a BC resource. But you know, we could bring this up next. We could look into it and bring this up next week.
Yeah.
In part 2.
Yeah, there actually are a couple of evidence-based programs that aren't on the top of my mind right now. Why don't we bring that to you? If we get it to the organizers and they can send it to the participants, would that be okay?
Certainly.
Okay.
Let's see. How do you determine what is ADHD and what is a trauma response?
That is a great question. So let me first state that if you look at children who have had traumatic experiences, those children are more likely to have underlying neurodevelopmental disorders like ADHD or autism. In other words, the children who have traumatic experiences, I'm going to state that again, are more likely to have autism and ADHD or ADHD as well. It's like double jeopardy. Both ADHD and autism, as well as trauma, they both cause emotional dysregulation. Very hard to tease apart, and you often have both.
I also like to add that sometimes when you don't know, because I often get calls and the youth has had a known trauma and people aren't sure whether to attribute everything to the trauma or if there's ADHD. I do find that it's sometimes helpful to try a stimulant because if the child does have ADHD and they do respond, that can also be really helpful. And we also can't forget that there's many youth that have, unfortunately, both trauma and ADHD. So it might not be an either or situation, it's an and.
Yeah, maybe I'll just expand on that. Let's say you're the kid who's living in a household where there is physical and verbal abuse, and you happen to be the kid who has ADHD and doesn't recognize, get out of dad's way when he's drunk. You've got ADHD to start with, and then you're the kid who's most likely to be exposed to a traumatic violence in that family.
Wonderful. In addition to the questions about the parent training program above, there are a couple of others around parent training and around screening tools that you recommend. So perhaps there's a resource that we can develop over the course of this series that we can post online afterwards.
Yeah, you know, Paul, at Compass, we have a number of different screening tools. Maybe what I could do is in next week or the third session, we could actually include them at the end of the presentation so that people can have them all. Or if you're able to email people out, we can do that too, because these are universal evidence-based screening tools, and we can do them for the common conditions that we talked about today.
Perfect, perfect. In discussing, this is the last question I think we might have time for. I'll share the others with you, Robin and Jennifer, in case there's opportunity to address them over the course of the series. In discussing impulse control and ADHD with emotional regulation, is it your thought that I'm going to kill myself from very young children will be influenced by untreated ADHD?
I think so. I think you still have to take it seriously, like any suicidal thought, but I do think that kids with ADHD, as we said in the earlier slide, that the impulsivity isn't just physical. It can also be like what they say and emotional dysregulation. And often it's not just I'm going to kill myself, it's emotional dysregulation in general. So like getting angry, temper tantrums, overreacting, being stubborn, things that are often labeled under the oppositional defiant disorder. I hate that diagnosis. And every time I hear it, I actually want to take a step back and go, what's actually happening for this child that they're behaving in this way? So I look at it like a fever. It's not a diagnosis, it's a symptom that there's something else going on, and it's my job to help figure out what's going on so we can treat the underlying cause.
Great.
Robin?
Yeah, I agree. In terms of oppositional defiant disorder, the two big treatable causes are ADHD and anxiety, which often underlie oppositional defiant disorder.
Wonderful. Thank you so much. I will share the remainder of the questions with you both after, so we can attempt to tackle them for the rest of the through the rest of the series. And I want to thank you both, Jennifer and Robin, for a really great presentation. There was a lot of questions and some engagement, and I suspect that'll grow over the course of the series. I want to thank all of our attendees for spending their time with us, and hope that they can depart with some practical improvement tools or ideas. And if you have not already done so, you may wish to register for the other two parts of this webinar series. Part 2 is happening next week. It's aggression in children with autism and related neurodevelopmental disorders. And that again is August 5th from 11 to 12 Eastern. And part 3 on case presentations will be on August 19th, again from 11 to 12 Eastern. And during that time, our speakers will be happy to respond to cases you share with them in advance. As well, we have another webinar on August 12th, and that will relate to applying principles of disaster recovery, psychosocial recovery to the COVID-19 response in healthcare systems and settings. You can stay up to date on all of our activities and events by signing up for our Spark Live newsletter and following us on Twitter at ChildHealthCan if you have not already done so. And so I want to thank you again for joining us today. Thanks to BC Children's Hospital for supporting our webinar program, and hopefully we'll see many of you here back next week. Bye, everyone.